Well, hello everyone. Glad you're here. Welcome to trauma and stressor related disorders. I'm going to go ahead and share my screen with you, and we will go ahead and get started. Okay, I think we're all set. Let's get going. Let's start off with just a working definition of trauma. You could look online and find a whole lot of different kinds of interpretations, but there is a central theme that runs through a lot of them. And again, it's this emotional response to a terrible event. Um, Now, the terrible events are of many different sorts. For example, it lists here uh, accidents, car accidents, falls, rape, natural disasters. And if you look online, you're going to see a lot related to war and the effects of war on children. Immediately after the event, shock and denial are typical. Longer-term reactions include unpredictable emotions, flashbacks, strained relationships, and even physical symptoms like headaches or nausea. While these feelings are normal, some people have difficulty moving on with their lives. Psychologists can help them find constructive ways of managing their emotions. Now, this came right out of, if you go onto the website at the APA, the American Psychological Association, this is what you'll see. And again, it's just one type of definition that you'll see amongst many others. One of the things that I'm going to call attention to here before we get started is this effect of immediately after the event, shock and denial are typical. I'm also going to mention here this other thing that some people have difficulty moving on with their lives. There is something about trauma that causes some sense of freezing. You just can't move on. You can't move on with your life, but you also can't move beyond your immediate environment sometimes. And this is one of the things that I'm going to talk about extensively in terms of some of the theories around why trauma has the effects that it does. A traumatic event has the effects that it does. And more importantly, some new research on how we might actually treat trauma based on some of the neuroscience evidence that's coming out in the research publications. Let's talk about some of the different types of traumatic disorders. The first one is a reactive attachment disorder. Inadequate attachment, when this happens, inadequate attachment happens in early life to a primary attachment figure that leads to the inability to seek or respond to comfort from a caregiver. Individuals may be emotionally and socially withdrawn and lack positive affect, or may be irritable, sad, or fearful during non-threatening interactions with caregivers. This is usually talked about and abbreviated as RAD, R-A-D. Children with RAD do not seek comforting nor respond to normal techniques used with children to calm them when distressed. They also may not respond positively to social cues of warmth and caring. They may come from impoverished environments. These might include nutritional impoverished environments or just simply physical necessities. Or they've gone through repeated changes in primary caregivers. They've gone through multiple placements. Symptoms are not due to autism spectrum disorder. They begin before age 5, and the child has developmental age of at least 9 months. So this is the criteria that is used to define reactive attachment disorder. Um, We have worked a lot, and I've worked over the years with some kids who are in the foster care system, and they've had multiple placements, starting off at not really super early ages, but ages such as 1.5, 2 years old, and they're just going through different kinds of placements because of domestic violence, which means that they get pulled out of one setting and put into another setting. Then they're with caregivers, and that doesn't work out, and they have to go to another set of caregivers. This is usually a pattern that I've seen with foster care families, at least here while I was working in Colorado. Okay, a couple of things about RAD and intellectual disabilities in particular. It's difficult a lot of times to make the diagnosis of reactive attachment disorder with intellectual disability. There are congenital and genetic factors that influence social behavior. And if a person has an intellectual disability, those things might be affected. And this brings up the second thing here, trying to figure out the differing levels of language and cognition. And if you can't do that, it will prevent distinguishing this 9-month threshold window that's required for reactive attachment disorder diagnosis. On the development and course, there's an inability, again, of an attached to a caregiver. This occurs prior to 9 months, but the diagnosis can be made after this window. Children with intellectual disabilities more likely to experience pathogenic care environments. That is, a lot of times institutionalized children come out of, intellectual disability children come out of institutionalized settings. There's oftentimes a high number, again, of these foster care homes. This is, again, the pattern that I've seen, particularly here in Colorado. I've seen the same thing happen in Florida. So I'm pretty familiar with this kind of environmental arrangements that can give rise to reactive attachment disorder. The prevalence, there's borderline to mild, ages 5 to 9. It's seen in about 16 to 18%, and they show symptoms of reactive attachment disorders. The second type of traumatic disorder is quite different, actually. It's called disinhibited social engagement disorder. This is when we have an inappropriate and developmentally inappropriate sociability with adult strangers, often exhibited through inappropriate closeness. That is, you'll see the situation where a child will sit on the laps of strangers, perhaps take their hand and walk away with them. They'll explore and move away from familiar adults without even glancing back to check in to go talk with strangers. This is also difficult to diagnose for the same sorts of reasons. Congenital and genetic factors that influence social behaviors may be at play when you are working with somebody who has this disorder as well as an intellectual disability. There are differing levels of language and cognition which prevent distinguishing the 9-month-old threshold. And then finally, a couple of things about this particular disorder that has overlapping features with ADHD in the sense that you see poor inhibition control. So what you oftentimes see are children who cuddle up next to complete strangers and seek comfort from complete strangers. And this raises the risk of sexual and physical abuse and having sexual predators who look for kids like this and could, take advantage of them. More recently, or more resistant to change, I should say, and it can develop before reactive attachment disorder and before 24 months. Now, one of the things that's definitely different in the prevalence between this and reactive attachment disorder is that rather than 16 to 18%. We're looking here at 37% showed symptoms of disinhibited social engagement disorder. That's 2 times more prevalent than reactive attachment disorder. Again, in a lot of the foster care homes, I've seen this kind of behavior as well. It's not really that uncommon when I've worked with kids who come from these kinds of environments. All right. PTSD, post-traumatic stress disorder. This is a chronic disorder that develops in response to traumatic exposure. Often it's cyclic and progressive. Symptoms compromise biological, psychological, and social functioning. Persons with ID are more vulnerable to the development of PTSD than the general population, as it turns out. Again, the data are not great on this, but it seems like that is the case, that persons with ID are definitely vulnerable to these kinds of situations, mainly because they're exposed to conditions which oftentimes contribute to PTSD. A lot of times, some of the households are not very stable. The living situation may, in fact, not be very stable. Um, and there may be things that happen in those environments which give rise to trauma. Persons with mild ID, the presentation is similar to the general population. But if you're working with somebody with ID, or I should say severe ID, the presentation is oftentimes complicated by different kinds of symptoms that you may see. Some of those symptoms, I should say, are complicated by the degree of communication of ability of the person who's trying to describe the traumatic event. There could be something that we call an acute stress disorder. These are symptoms similar to PTSD. They occur immediately following exposure to one or more traumatic events. However, keep in mind that it's important that the symptoms last from 3 days to 1 month. That's what defines an acute stress disorder. Anything beyond these time periods will give rise to a different kind of definition or a different type of a diagnosis. Symptoms from acute stress disorder include intrusive thoughts, negative mood, dissociation, avoidance, and arousal, or I should say hyperarousal. In the development, of course, of acute stress disorder, it can't really be diagnosed until 3 days after the traumatic event. Again, it's not 2 days, it's not 1 day, it's 3 days. This is really important because I've been in those situations where there are reasons why they have these different types of time criteria that have been decided upon, so that it's not just a brief reaction, but it is something which is traumatic. Again, 3 days to 1 month. Approximately 50% of individuals have had PTSD. That's pretty staggering when you think about it. Half the population has had some degree of a post-traumatic stress disorder. In prevalence, it's been identified in 20% of the cases following traumatic events and up to 50% for interpersonal events. Assault, rape, mass shootings are just examples of the possible acute stress disorders that people can experience. And this is, again, in the general population. We don't really have data on the ID population, but if we're looking at the general population of 50%, possibly, and we're also looking at the fact that there's a good chance that persons with ID have the greater probability that they'll experience stressful environments or situations, then the number goes beyond 50%. It probably goes at least higher to 60 to 70%, perhaps. There's a segment of disorders that are traumatic disorders, adjustment disorders. In fact, the very first person I worked with mental health issues was back in 1985, and he had an adjustment disorder. He was just coming out of an institutionalized setting in Massachusetts. He lived there all of his life, and when he was there from birth until the time he came out, which was essentially he came to me. Um, I would say he was probably in his early 30s. So this is a lifetime of institutionalized behavior, institutionalized lifestyle, and everything that goes into it in a state school. Um, so an adjustment disorder is when you see a clinically significant emotional or behavioral symptoms in response to an identifiable psychosocial stressor or stressors. In this guy's case, it was going from one environment for 30 some odd years into a less restrictive residential home with five other persons. The stressor may be a single or multiple event. It develops within 3 months of the stressor onset and typically resolves within 6 months of the termination of that stressor. What you oftentimes see, and I have this in red for, again, a reason, you see a lot of times when people undergo these stressful situations, you don't get an immediate response. You get oftentimes passivity. And passivity is something that happens when we're exposed to stressors. We don't always get activated. We don't always have reactions. And sometimes passivity becomes the going strategy that we end up developing, which is one of the reasons why this particular diagnosis stresses it develops within 3 months of the onset. Because again, it's understood that in a lot of times when you're working with folks who've had this problem, the first 3 months they're under a lot of stress and they're passive. And then you kind of follow them, and then you find out that they have undergone some degree of a stressful situation, whatever that may be. And now they're starting to seek help. This is what we call a delayed escape response. It took about 2 to 3 months, perhaps, before they were able to respond following the stressful event. And now they're making a response. So that's one of the things that we oftentimes see in adjustment disorders. The magnitude of the distress oftentimes exceeds what would be normally be expected. In this gentleman's situation, there may be stress when a person moves from one environment to another, from an apartment to another apartment, from one house to another house. The person may experience it, the family may experience it, but this is different. This is definitely different with this guy because, again, he didn't know any other lifestyle but 30 years of living in an institutional setting. He really had no conceptualization of what it would be like living out in a community-based program or a home with less, less than a ward of individuals. Now you're only living with five other individuals in a house. Very different kind of an environment. You got to also consider the context and the culture in which a person lives. You got to take this into consideration as well. That is, what may be non-stressful for some people or a therapist may be very stressful for a person who's coming from one culture and one context to another living situation or lifestyle situation. An adjustment disorder diagnosis does not apply when symptoms represent bereavement. Bereavement is its own category in the DSM-5. And we recognize, again, that bereavement may take some period of time before a person is able to actually feel differently from their loss. But bereavement is not an adjustment disorder. Okay. All right. These are different kinds of adjustment disorders. We could have an adjustment disorder with depressed mood, with anxiety and depressed mood, disturbances of conduct, with mixed disturbances of emotion and conduct, which is the gentleman that I was working with back in 1985, or an unspecified adjustment disorder. It doesn't necessarily meet the criteria of any of these five above it. In the development of course, it must be a reliable source for history to confirm this 3-month timeline for onset. In this case, I was referred to to look at the records from the state school that this individual came from. And I was able to get this pretty readily from his residential director. You just get a release of information and there you go. And now you could track exactly all the information about the discharge information from the state school and then the transition from the state school to the residential home. You must be aware of various sources of stress may seem innocuous for some persons without ID, but very significant with persons with ID. Again, doing something for 30 years, it may be very, very difficult to comprehend what that sort of situation means. But then again, I don't have an intellectual disability. So what may be innocuous to me, saying 30 years of this, and now I'm going to be in a less restrictive environment where I have my own room and I have access to food and I could go out into the community and do the things I'd love to do. For me, that sounds a lot better than what I might be getting in a state school. But for this individual, it meant a less restrictive environment meant higher expectations. He had to be involved in making his own food and money management, and he had to work in a day program, and he had to follow different kinds of rules. Um, Everything was not arranged for him. There was no set schedule. And he had been used to this regimented schedule for so long. He just got used to it. You know, he didn't have to make his own food. He ate in the cafeteria. He never had to clean the food. He just went in, they ushered them in, had them sit down, had them eat, and then that was it. The meal's over, they go back to their rooms. Um, and now you're making a person, in a sense, switch that environment and go into an environment in which those expectations are no longer there. He's now got to kind of do a little bit of work for himself. That's the expectation. Um, and that was the challenge for him. The prevalence. Again, this is very likely underdiagnosed in the ID population, but what they do see is essentially 1 to 3% of the ID population have adjustment disorders. I'm going to describe briefly some treatment options and some of the research that has been done about these treatment options for trauma. A study by Byrne did a meta-analysis review. And again, meta-analysis reviews are these big reviews of information gathered from a variety of different sources. It's quite an undertaking. And in this situation, they were looking at treatment interventions for PTSD and intellectual disabilities. From 2010 to 2020, they compared the effectiveness of EMDR, which is eye movement desensitization and reprocessing, and CBT, cognitive behavior therapy, in adults and children with varying degrees of intellectual delays. Both were found to be effective, both EMDR and CBTs. But again, a lot of the things that they found out about these studies, they're not very well constructed. They're not very well designed. They're weak methodologically. They have small sample sizes. They really don't have large sample sizes that you could kind of take a look at and do statistical analyses on that are better than the small sample sizes. They lack standard assessments and treatment designs. So you're kind of comparing a lot of times apples and oranges. Even though you're looking at EMDR and CBT, they may be using very different kinds of approaches. Study by Kiesler in 2020 did a similar kind of review. It was not necessarily a meta-analysis, but it was a literature review from peer-reviewed literatures from 2008 to 2018, comparing the following. They looked at parent-child psychotherapy, exposure therapy, trauma-focused CBT, and EMDR. All of these were found to be effective, but once again, they had the same limitations to the methodologies and sample sizes. So that's just one of the things that again speaks to the fact that there's just not a lot of very good data that's out there. But I think one of the things that at least you see there is at least somebody's publishing some degree of research on whether these things are effective or not. It just doesn't really meet the stringent criteria that is oftentimes set for, good research. All right, I'm going to change gears here, and I'm going to talk about some of the treatment options that are important to think about when we are thinking about um, trauma. And this is some work that has come out of the writing and research by Dr. Camille Kolu. I've had the pleasure of knowing Dr. Kolu for quite some time, and I have seen a lot of her uh, research evolve over time relative to the question of what she calls the need for a trauma-informed culture. That is, we should operate under the assumption, the possible assumption that people who come to us for a variety of reasons may have experienced trauma at some point in their life and should be on our radar as we are able to try to understand what may be going on in their world. Okay. So, one of the things that she calls for is an understanding of unique histories of individuals and families. Very unique. I work with a very diverse population, and I see so many differences between different cultures and different backgrounds. And I need to understand how those impact the behaviors and the symptoms that I'm actually seeing when I'm doing any kind of evaluation. So she always asks the question, Dr. Kolu, are we being evidence-based with respect to unique cultural contingencies? What might those actually be? Well, in particular, our interests, our mutual interests, mine are in traumatic brain injury, hers are in trauma and informed cultures, trauma-informed culture and treating trauma individuals. But we both have ties to applied behavior analysis and to behavior therapy. And so one of the things that she asks are ABA or behavior therapy treatments met with resistance or with barriers? When we start doing any kind of treatment for a person who we suspect has had trauma, do barriers come up that we should be immediately aware of that should be signals to go slowly, tread slowly, perhaps just stop and look closely at what may be going on behind the scenes. The other thing that she says is important. Do the rules and regulations for providing treatment clash with cultural values or beliefs? One of the things that we are oftentimes faced with, and I've got some examples down here, stuff that I've had to work with over the years, is in providing treatment, we have to follow certain kinds of rules, certain types of protocols, which become what we call standards of care. The question becomes, have the standards of care that we've established for our own profession, do they clash with family expectations, with family beliefs and family values? Have we put ourselves into a situation that in order to be in compliance with certain rules and regulations, we go into the situation automatically 2 steps behind the beat, so to speak, in that the family does not understand these rules and regulations, and they question why we are actually doing some of the therapies that we are doing. Some of the examples I have down here is something that we call dosage. When a child with autism spectrum disorders oftentimes gets evaluated and reviewed, they are asked to, the therapy folks are asked to uh, put forward a projection. How many hours will this person be requiring for treatment? Will it be 10 hours a week, 20 hours a week, 30 hours a week? And by the way, we haven't even asked the question of trauma yet. Hang on a second. So just that alone, the trying to teach a family to understand that when you do these assessments and some of the recommendations that come out, we make recommendations or therapists make recommendations that they feel are in the best interest of the individual. That's how they do this. It's oftentimes the best thing that they could possibly do. But in coming up with some of those numbers, they sometimes are pretty high, sometimes 20 to 30 to sometimes 35 hours, maybe 40 hours is required. And for a family to understand what that means, um, that there's going to be therapy that has to be done for a bulk of the week. It's not just like medication where you give a pill 2 or 3 times a day and that's really it. This is a whole different kind of dosage. That brings up the second kind. A lot of times with some therapies, they recommend in-home therapy. That could actually be in-home ABA. It could be in-home OT and speech. I've worked with families that get all three of those at one point or another during the day. Now you're going into people's homes and providing treatment, and you are now crossing into their personal boundaries, their lifestyle. You start learning a great deal more about the family than you did if they were to come into a clinic. We expect participation by the parents. This is a very important thing. This is why we do a lot of psychoeducation with the family. And we hope that we could get family buy-in because a lot of times it's not just the therapist coming in to do the therapies, it's whether they are able to take this information home with them and do homework and what the expectation is. That's certainly an expectation on the terms of a lot of funders that they expect the families to get involved with the treatment. Caregivers as well. Caregiver training is very, very important. And there are certainly barriers to being able to provide some of those trainings. One of those is funding. So when you're looking at these kinds of things where the family is saying, we really, really need some help, but there's no ability for us to actually go in and do any kind of training that would really help and benefit the family, that's what I'm talking about, that we are kind of stuck in these situations that are not really favorable to the family, to the culture in which they live in, and it does not really recognize their personal values. And you have to find yourself straddling two different worlds. One is again doing the culturally right thing, the trauma informed um, practices, as well as making sure you're following the rules and regulations. So concentrating more a little bit on some of the ABA stuff that Dr. Kolu has, lectured on so many times. Uh, she says that we should be aware of some of the ABA procedures that may be contraindicated after trauma. And here are some of the red flags that she says we should very, very, very tread very carefully on. There may be individuals who have had deprivation and they have food insecurities. There may be some food related abuse, maybe neglect, food deprivation. This is definitely a red flag if we know that a person has had these kinds of issues related to food. Sexual and physical abuse should clearly be red flags before we go in and just start doing ABA treatment. We may have to, again, adjust our treatment and our assessment models based on some of the things that may be contraindicated. Medical complications related to sexual or physical abuse is similar sort of thing here. We want to be extremely careful going forward with treatment when the person's actually undergoing medical complications and the things that we're asking them to do. Behavioral problems that are related to undiagnosed medical issues, such as celiac disease. These could be pretty traumatic as well. Adverse circumstances, death of a parent, removal from an unsafe home, immigration, poverty, inconsistent caregivers in childhood consistent with reactive attachment disorder. And then finally, if a person's had involvement with law enforcement or school suspensions, we want to be, again, very careful how we go into providing ABA treatment in particular, because some of the procedures that I'll talk about, which might be good to do in the general sense, might not be such a good idea to do with people who have undergone a history of trauma. So Dr. Kulu suggests a couple of things here. Carefully consider the treatment plans that use the following: any kind of edible reinforcers, any kind of one-to-one interactions without oversight. That is, providing one-to-one treatment behind closed doors, where nobody could actually see what's going on. And in our centers in the past, we've actually had the doors open during all of our sessions so that we make sure that everybody has access and free access to come and go from the individual classrooms. Toilet training procedures should certainly be very carefully thought through. Attention extinction. This essentially is where a person is asking for attention in inappropriate ways, and you say to yourself, I'm going to teach them an alternative to getting attention. Before you run an extinction procedure in general, which I always have some problems with because it's not easy to run an extinction procedure. But a person may need to have that attention, and they come from an environment in which they've been deprived of any kind of attention for behaviors of any kind. So in this sense, sometimes we talk about attention extinction as a good procedure, but not necessarily with somebody who's undergone trauma. The same thing is true of differential reinforcement for appropriate requests. We may actually want to accept inappropriate requests initially to get the behavior under control and then shift over to appropriate requests. But again, we got to be very, very careful that we're not pushing this issue too much. Timeout from attention reinforcement. Again, timeout procedures have oftentimes difficult to implement, particularly when the person has very high scale behavior, and putting them in timeout might not be the best idea. Contingent praise statement for compliance. Now, why would that be a problem? Well, one of the things that oftentimes happen is that if it's not done right, sometimes people oftentimes will use contingent praise. The individual engages in some sort of challenging behavior or inappropriate behavior afterwards, and then the caregiver or the parent comes in with a corrective statement. And what happens here is it becomes behavioral chaining. That is, contingent praise becomes a signal to engage in possible inappropriate behavior in order to get reinforcement in sort of inappropriate ways. So this is what we call behavioral chaining, and it oftentimes happens because we start off with contingent praise statements, and those become things that are not actually discriminative of positive reinforcement. They become discriminative of acting out and getting a timeout and then getting out of an environment. I see this a lot in classrooms. This is one of the things that is one of the number one problems, in which if you really don't know how to deliver positive reinforcement, it sets up a situation where kids will stay in the room long enough to get the positive reinforcement, act out, and then be able to get excused and go somewhere else to escape and avoid further demands of the classroom. Not uncommon, okay? Finally, least to most punishment. and the use of punishment in general. Coercive practices. I don't have time to go over all of those coercive practices, but there are a lot of times in which some of the procedures that parents and caregivers use are coercive. And we have to be extremely careful not to use a lot of those practices which utilize coercive things such as negative feedback, um, backhanded compliments, those sorts of things, telling a child that they're bad, uh, implementing the use of timeout, implementing the use and misuse, I should say, of extinction. These are some of the things that I'm very, very cautious about in general, not just with children who have undergone trauma. But Dr. Kulu definitely points out here, these are some of the things that are oftentimes used in behavior ABA programs that they have to be thought out very carefully. To arrive at a trauma-informed culture, Dr. Kulu suggests a couple of things. First of all, supervise and train for trauma. We should be training individuals how to deal with trauma, as well as how to deal with general kinds of problems, as well as specific problems. You always want to assess and document risk whenever you're using certain procedures. And we oftentimes talk about something called a functional assessment of behavior. We want to possibly do the same sort of thing in terms of doing a functional behavioral assessment on the history of an individual, not just the immediate behavioral functions. Is this attention seeking? Is this escape and avoidance? Is this trying to get tangibles? Is this related to physical things, such as physical ailments? Those things are important in the moment to find those immediate functions. But we also want to think about historical ones. I'm going to be talking about this in a couple of minutes here, that when we're trying to come up with functional reasons for a person's behavior, we oftentimes try to do the immediate ones. What Dr. Kolu is suggesting, and I'm certainly supporting her on this idea, is that the same thing can be done on historical variables as well. That we look for not only the immediate, but the ultimate causes that led up to the reason why we see immediate functions as they are. And the problem here is that when we're trying to do this, getting clinical records might be very difficult if you could find any at all. This has always been the challenge. How do we find out a person's history? I had really nothing to go on with my gentleman who was from the state school, and he had this adjustment disorder. Couldn't find really any records. But then again, that was going back to the 1980s. It was a whole lot different. And today, there might be better records that are kept with individuals. Certainly, kids who are in public school, they have good records, I would imagine, with IEPs. And that gives us a source of information, a little bit about some history on an individual. So in comparison of looking at a standard treatment procedure versus a traumatic informed procedure, let's look at the left side over here first. If we go into a situation as ABA therapists oftentimes do, there are 4 things that oftentimes are taught in ABA programs, in teaching persons with registered behavior therapists, RBTs. These are 4 things that you always end up doing whenever you're running programs with individuals. And I call this standard treatment procedures because this really is standard treatment procedures and what you're taught to do when you go in and get trained to go in and work in a lot of the settings with children. First thing, pair the clinician or behavior technician with food and fun. In other words, you establish yourself as a reinforcer. You're a fun person to be around. Hey, let's go get some snacks and we'll go to the cupboard and we'll get ourselves some, maybe we'll get some chips and dip, or we'll get some cookies and milk, or we'll get something along those lines. So you try to pair yourself with certain kinds of food as well as fun activities. Whenever a person looks at you, you oftentimes are told to reinforce eye contact. Say, hey, nice work looking at me. Okay. And again, this is working with small children, oftentimes with intellectual disabilities, um, and the possibility of autism spectrum disorders, right? The third thing, conduct standard preference assessments. Always try to find out what your child likes. What's their favorite thing? What activities are their favorite things? What foods are their favorite things? What are also really important? What's not their favorite things? What do they dislike? What activities do they escape and avoid from? What kinds of foods do they just shy away from and they say, ooh, right? Knowing all those things are very important in terms of standard treatment. The final thing is use reinforcement, positive reinforcement, once you find those things that are reinforcing, and require compliance. And that compliance could be just simply saying, ask for more. Would you like some more chips? Would you like some more dip? How would you like some watermelon? Okay. And we would ask them to just respond by saying, yes, please. That would oftentimes be it. Okay. So this again is, like I say, standard treatment protocols that we would typically use, typically train registered behavior technicians to do. I'm going to flip over to this side over here to trauma-informed procedures, which adds a different level of analysis to what you just saw here. It incorporates context and circumstances analysis, as well as best practice for the population. What I said here on the left is considered to be best practice for the most part, but you have to look at the context and circumstances in which you use those things. And do you really want to make eye contact something which is absolutely positively needed in order for a person to gain social reinforcement and praise? Some people don't like eye contact. Some people shy away from that. Should that be one of the circumstances? And if a person's undergone trauma, there may be reasons why they don't want to make eye contact with you. Okay. Secondly, you want to always list the risks and benefits of using these different kinds of procedures. We always do that in just about everything that we do. We do it in medical science, right? We do it with psychotropic medications, the risks and benefits. With ADHD medications, we list the risks and benefits. We certainly want to do the same thing with ABA procedures as well. We want to determine the prerequisite skills needed for the benefits. They could achieve the benefit, but what do they need to do to be able to get to the point of getting those benefits? What are the prerequisite skills? Do they have them? Or are they kind of very low down because of this history of trauma? Must we work on getting past the trauma and work on that issue before we could even achieve some of the benefits that we are describing to the family and the individual? We also want to point out what's the worst case scenario if risks do occur. What could possibly happen? Okay. And we want to take those things into consideration. And then finally, we want to determine the best course of action and the best course of communication. These are what we would actually call trauma-informed procedures. We are not saying to not do these other things here. What we're saying here, and what Dr. Kolu is recommending, is that we incorporate all of these things in looking at what we call standard treatment procedures. Okay. All right. I'm going to switch gears here because I'm going to go over something that I have mentioned before in other lectures. And I'm going to bring it up here because this becomes a good opportunity and a great segue into the topic that's going to come up next, which is basically the neuroscience that we understand, which may underline trauma. I mentioned before that models are very useful. Models help us describe events, help us communicate events, and help us forward in terms of organization and structure of the concepts that we're thinking about, the ways in which we approach certain kinds of behavior and certain kinds of disorders. So I'm going to kind of go through once again the four causes of behavior briefly, very briefly, and show you how this relates to trauma. And then we'll go right into the neuroscience. The first kind of cause that I had mentioned before is an efficient cause. Efficient causes essentially describe triggers for behavior. Questions: under what conditions does a behavior occur? Why does this symptom seem to occur? And one of the things that we oftentimes will see are when people undergo trauma, there are things that happen in the environments which are signals, signals which indicate certain changes in conditions and contingencies, which come to define the traumatic event. What makes one event more traumatic than another? How do we look at that? What sets off the occasion of the symptoms when a person relives trauma? They're seeing some of these triggers over and over again. Either they're out there happening externally or they're happening internally. The second kind of cause is the material cause. When a person's undergoing trauma, we see symptoms, but what's really going on underneath the system? What is the substrate? What are the mechanisms that underlie when a person is essentially frozen and can't move from the trauma? And then eventually they do develop some sort of resiliency, and they're able to slowly emerge from the trauma and get past it. Again, remember what I was talking about with the definition of trauma from the APA. It's this idea of being able to move on, this idea of being frozen and not being able to actually make decisions. What is that really all about? So this cause we're talking about here is when we see this happening, these are how questions. When a person freezes, how does the neuroanatomy respond to these triggers that I just mentioned right above it in efficient causes? Okay. The third kind of cause is the reasons, purpose, and function behind behavior, behind the symptoms. These are what questions. What is happening when a person engages in these kinds of responses? Is there some sort of adaptive feature that may actually explain this particular behavior, that we should exhibit these symptoms? Sometimes the idea that not behaving and not doing anything might be a better strategy than responding in a very haphazardous way, which might put yourself in a further traumatic situation again and again and again. So rather than doing that, sometimes freezing can become an adaptive strategy. It could also become a very detrimental one if the person is frozen and can't move to get out of the situation, period. Again, what we're going to be looking at here are two kinds of final causes. Typically, one, the immediate one, and the immediate trigger the person's experiencing, perhaps right before your eyes. The other one is the final causes, the function of doing a functional assessment of a person's history. Try to get back to understand what might have happened in the traumatic event, the original one, the original evoking event that gave rise to the trauma. And therein may lie some of the information that is necessary to get at a possible solution to getting out of that situation. Okay. I'm going to come back to that because what I'm not talking about here is rehashing history. That's not what I'm talking about. And I'm going to save this because there's reasons why we don't want to do that. Okay. The final thing again is formal causes. It's a final theory. It's a theory that explains and puts all of the facts together as we understand it. So here's where the model comes into play. I've gone in and talked about the efficient causes. We've talked about triggers. We've talked about the possibility of things which happen traumatically to a person. Um, we've talked about the function purpose of why these behaviors may be there. And one of those things may actually be is that it could be adaptive to not do anything and just stay put where you are rather than going ahead and engaging in some sort of behavior that makes this situation that much worse. Okay. What we have not really talked about is this one right here, the how questions. What is the underlying substrates which make all these things actually happen? Okay. In other words, when we look at passivity following trauma, and this is the problem, I put the problem right in the middle. It's passivity following trauma. We oftentimes look at the causes and the triggers which lead to trauma. These are the efficient explanations. We oftentimes look at what does trauma and what does response achieve? Are there secondary gains? What are the outcomes to be gained by being passive in the face of trauma? What we're talking about here are functional explanations. The third thing that we're trying to talk about now is this one. How is passivity following trauma embodied in the neuromechanisms of the brain? These are the material explanations that I want to talk about now. And to talk about this, I'm going to bring up some research that was done back in 1975. That's the starting point. In which some research by Marty Seligman, in which he looked at byproducts of aversive control. I'll go over the procedure here shortly, but one of the bottom lines and summaries that Seligman talked about was this idea of helplessness. This is the big problem with depression. It's the big problem with trauma because in both situations, helplessness and depression, it leads to the situation in which you cannot move beyond the event that actually took place that gave rise to the situation, which is helplessness, not being able to get yourself out of a situation. And this is what he's talking about. He says helplessness happens when some outcomes occur independent of all operant or voluntary responses. That's what helplessness is. And he used to say quite often, it's the belief that nothing one does matters, for good or for bad, that there's nothing that you could do to alter your current situation for better or worse. So he kind of defined depression in an interesting way. It's in a way that I find important, particularly in what I understand with head injury and traumatic brain injury. There's really two ways of looking at depression. One is that depression refers to passive individuals who believe that they cannot do anything to relieve their suffering, such as losing an important source of nurture. When a person's loved one passes away, when a parent passes away, a sibling passes away, or a child passes away, and there's nothing that you could have done to prevent it. Everything that you've done was out of your control. Um, they got into an auto accident. They had an injury of some sort. They developed terminal cancer. Whatever the source may actually be, there was nothing that you could do to make it better or worse. It was out of your control. That's certainly one type of depression that is seen. This leads to a person who becomes passive and doesn't really know what to do to relieve the suffering. But there's another kind that is called agitated depression, in which patients who make active responses to escape and avoid a situation, and then they become depressed with no obvious external cause. But there's a heightened level of agitation to try to escape and avoid the situation. These are two kinds of ways of examining depression, but Seligman, believed that helplessness was the result of a psychological phenomenon and not necessarily a physical deficit. Okay, and that's our starting point for some of the research. Seligman was able to use this particular figure to describe and make his point clear of what he talked about with response independence. That is, you could have a situation where you have to do a behavior to get the reinforcer that you want, or you refrain from doing behaviors to get the events and the reinforcers that you want. Let's start off with the one that's what we call response dependent. If we have a scenario here that I'm looking at this figure, okay, and what you're looking at here is 0 to 1.0 here, 0 to 1.0 up here. Let's concentrate for a moment on this one right here. What this is looking at on this axis is the probability of an outcome given a response. It's the probability that you will get something as an outcome if you do a certain kind of behavior. Respond, get outcome. When we have a scenario where every time you respond, you get the outcome, it's continuous reinforcement. It's 1.0. This is what happens when I go to a vending machine. And all things considered, that everything I've got works and that the machine is plugged in and it's loaded with whatever is in the vending machine. It may be coffee, it may be Coca-Cola, it may be, candy bars and chips, right? But every time I go there, I put my money in, bang, I get what I'm asking for. That's continuous reinforcement. That's the response happens, given the opportunity to respond, and the outcome, given a response, it's 1.0. In some situations, I don't get positive reinforcement every time I respond. Sometimes I do, sometimes I don't. That shows you that in the real world, it's really between 0 and 1.0 that we live. We don't live in a world of continuous reinforcement. We live in a world of partial reinforcement. Let's go back to a machine such as a slot machine in a casino. A slot machine in a casino pays off not on continuous reinforcement, but on what we call intermittent reinforcement. It occasionally pays off, not always, but sometimes. And what you're looking at here is the probability of a response that may be between 0 and 1.0. Those machines are set up to probably reinforce maybe at 0.65, right about here. So we would put the dot right about here on this spot right here to indicate that this is about where the reinforcement contingencies lie in slot machines and casinos. Okay. You may have a partial reinforcement that's lower than 0.5. That may be down right here. That's even less favorable than that. What might that be? Scratch tickets. Scratch tickets really don't pay off nearly as well as some of the cheaper ones of the slot machines in the casinos. Okay, they pay off with less reinforcement, and the probability of getting reinforcement is much lower. Okay. Okay, so this is the world of response contingent reinforcement. Do behavior, and the outcome depends on the response. Okay, must have a certain type of response that's defined. But there's another kind that I'm going to point out right now, in which if you don't respond, you get reinforced. Okay, if you don't make a response. And what this says here is that R bar means no response, non-responding. It's the probability of an outcome given that you refrain from making a response. Okay. This is called DRO, or differential reinforcement of other behaviors. And you could have contingencies that are 1.0. What are some of those contingencies? Where could you get a reinforcer if you refrain from behavior? Good question. And here's a couple that I could certainly name. One of them is refraining from alcohol use and substance use and narcotic use. If you are a member of AA, one of the things that happens is that when you reach 3 months or 6 months or 1 year, that you have abstained from using any kind of alcohol, you get a small medallion. So the probability, the outcome depends on non-responding. The longer you go without drinking, the more benefits and recognition you get for, wow, look how long I've gone. This is a new one for me. Okay. Certificates of deposit. What are those? That's when you put your money into a particular account, and you are reinforced when you refrain from engaging in taking the money out of that certificate of deposit. It usually has a certain length of time. It may be a 1 year, 2 year certificate of deposit, but you put in a certain amount of money. Maybe you put in 80 bucks. After 1 year, if you don't touch that money, you could take it out, it'll be 100 bucks. Okay. That's a certificate of deposit. It reinforces the behavior of not responding. Okay. And those, again, are sometimes yes, sometimes no. Sometimes you get those reinforcers, sometimes you don't. So this is the world that Seligman believes we usually live in. He believes that we live somewhere between partial reinforcement most of the time in our lives, okay, that are controllable to some degree through our own behavior, and less so, it's controllable through our own behavior, but it's the absence of behavior, okay, that actually gets reinforced. Here's the dangerous area. You see this 45-degree angle? This is the line of response independence, which essentially means is that the reinforcers that you're going to get are just as likely if you respond as if you don't respond. It doesn't matter. You're just as likely to get it if you do respond or you don't respond. And that's this response independence here. And what he kind of looked at here was what happens when people are experiencing aversive traumatic events, and the events occur along this line. This is where helplessness takes place. What he's talking about here is the fact that behavior, responding, does not get you out of the trauma. Okay. So if you make a response, you're just as likely to experience trauma. If you don't make a response, you're just as likely to be involved with trauma. It's this damned if you do, damned if you don't. It just doesn't matter one way or the other. And this response independence leads to what he says helplessness. Okay. I'm going to quickly go over an experiment that Seligman and his colleague, Stephen Mayer, did way back in 1967. In this study, this was a brilliant study in psychopathology for its time, and he used something called the triadic design. He had three groups of subjects. These were rats. And with the three groups, he had different experiences that each of the groups had undergone. So let me describe to you what each group did. I'll start with group one, then go to group three, then I'll go to group two. Okay. Group one, this was called the escape opportunity group. In the pre-treatment, before the experiment started, these rats were exposed to, they were in these, essentially this chamber that was completely enclosed, and it had a wire grid floor. Through the wire grid floor, Seligman was able to apply mild electric stimulation, electric shock, to the grid floor, which got the animal aroused. It was not detrimental. It was not anything like that. It was just it was intense enough to be noxious without being necessarily dangerous. Okay. And they've replicated this in a number of different ways, not only looking at first at electric shock, but they also looked at bright lights, loud sounds, a whole bunch of different kinds of aversive features that were used. I'm going to talk about the one that I'm most familiar with, the one with the electric current that was in the grid floor for the group one subjects. Okay, so this electricity would come on, this little grid floor would become active, and what the rat had to do was go over to a lever, press a lever, and turn off the shock. That's all they had to do. The shock would be shut off. It would be shut off for a short period of time, and then it would be turned on again. The rat would go over, press the lever, turn the electric shock off. This is escape opportunity because the rats were able to escape the aversive event through shaping, and they were effective, very effective in doing this. This was the pre-training. Okay. Um, Group two had no pre-training at all. I'm going to come back and talk about them in a second, but they had no pre-training opportunity. Group number three also had no pre-training opportunity. Group two and three had no pre-training. Only group one did. So the first phase, like I said, was this pre-training of escape opportunity for group one. The next phase involved the other two groups. Group two was now, the term is yoked, which essentially means is that there's no lever in the chamber. Okay, there's never a lever in the chamber for these animals. All that's in there is four walls and a grid floor. Okay, that's the only thing that's in there. Now, the floor would become uh, electrified and a shock would be delivered only if the subject in group one receives electric shock. So here's what happens. You have two groups, they're paired together, two subjects from group one and group two, and then you get another couple of subjects from group one and group two. They're all paired up. So group one has subject A, and they're going to receive a brief electric shock. If they could turn off the electric shock, they turn it off for themselves, but they also turn it off for their partner who's in the other chamber, who's also getting shocked at the same time. Okay. There's nothing that group two could do themselves to escape and avoid the opportunity, the shock, because they had no opportunity. Okay. Now, here's what group one had to do. Group one, after they learned to press a lever to turn shock off, and they were able to do it in really very quickly, they changed the condition. And instead of using a lever, they took the lever out. And now group one had to learn a brand new escape response. And here's what it was. Half the floor of the chamber was actually electrified. The other half of the chamber was not. So when the electricity was turned on, all that had to happen was for the rat to essentially jump over to the other side, from the shock side to the unshocked side, and escape and avoid. Uh, they were able to do that quite readily. But here's the thing. The minute the shock was turned on for group one, for the one subject, it was also turned on for number two, who did not have that same arrangement for themselves. They did not have an opportunity to go to the other side of the chamber because the whole chamber floor was electrified. It didn't really matter. The electricity for group two was only turned off if group one subject was successful. So that again defines escape versus the no escape conditions. Okay. All right. Group number three, they didn't get any pretreatment. All they had to do was learn one thing. All they had to do is the minute the electric shock was turned on for them, it was on half of the grid, on half of the floor. They just had to jump to the other side and they would escape and avoid. That's group three. They were the control group. Okay. So what were the outcomes? Very simple. Group one, because of this history of learning to escape and avoid, because they were able to do it successfully with a lever, they had learned that their behavior can control the aversive event. Not necessarily the onset of it, but they could certainly control the offset of it by turning it off. And they did this quite readily. First by pressing the lever, then by just scrambling and jumping over to the other side. They were doing it instantaneously. Interestingly enough, group three was able to learn it instantly too. Even without the pre-training, group three was able to actually escape and avoid without any problems. Group two could not. And here's the interesting thing with group two. After group two went through this history of no escape opportunity, that they just had to sit there and take it and freeze, and there was no opportunity to control the electric shock. Now, when you give those animals the opportunity to do it, that they could just simply jump to the other side of the chamber, they don't. They have learned to become helpless. They don't make escape responding. This is the helplessness group. And again, it's because they were in a situation where they have a history of there's nothing they can do to make their situation any better or any worse. They just had to kind of sit there, take it, and their opportunity to control it was the outcome was dictated by another animal in another chamber in another situation. Okay. Some things that were noted in these, and by the way, it didn't matter if you used electric shock. The same thing held true if you just remove the electric shock and you use loud sounds, noxious noise, noxious frequencies. The same thing will hold true, that you'll get the same kind of behavior developing, that the animal will learn to be helpless and not be able to learn to scramble to the other side. If you take group two, by the way, and put a lever in the chamber, they won't be able to learn how to do that. It takes quite a while for them to learn to engage in escape responding when there's a lever in the chamber. Here's some other things that happen with inescapable aversive events that Seligman and Mayer noted. First of all, whereas there are certain stimuli, if you put rats in a chamber together, and you put food in there, limited amounts of food, you could actually see some degree of aggression between rats under certain circumstances. If you take one of these helpless rats and puts them in this situation, they're not aggressive at all. They're as passive and calm as not calm, but I would say very, very, very passive and docile. Okay. They don't have social dominance. They don't try to take advantage of other species. That's absolutely reduced. There's a reduction in food and water intake. They stop taking in and they start losing weight. There's an exaggerated attention to external cues. Anything that comes along, they freak out, and there's an increase in general activity rather than calming. If you bump the chamber, which is an external cue, or you just suddenly turn a light on in the chamber, they have this exaggerated attention to this hyper arousal. There's a reduced preferences for sweet tasting things. There's potentiated fear conditioning. That is, now if you want to take those same rats and do some fear conditioning to shape up something like condition suppression, it's much easier to work with these animals because they'll respond to fear stimuli much faster than animals that have not undergone this helplessness kind of arrangement. Fear extinction takes longer, much longer, with animals that have undergone the helplessness group two kind of scenario. Neophobia. Most animals will actually be curious to sniff and explore environments. These animals don't, they cower and they just sit in a corner. They don't explore um, things that most rats would. And then finally, noxious behaviors, I'm sorry, anxious behaviors. You see a big reduction of social exploration, and these animals, quote unquote, just look anxious as heck. Okay. It's like everything gets them scared and freaked out. All right. So the theory at the time by Seligman and at the time by Mayer was that it's not the aversive event itself, but learning that the aversive event is uncontrollable that causes helplessness. Remember what's important in Seligman's experiment. You can't say that group 2 got more electric shock than group 1 because they were yoked. That was the brilliant way of looking and controlling for that particular variable. If group 1 got shocked, group 2 got the same amount of electric shock. There was vast differences between those two groups, big time differences. So he talked about the fact that it's not that shock itself that causes helplessness, but the fact that shock is uncontrollable that causes helplessness. He believed that helplessness is a cognitive process in which people and other animals learn that outcomes are independent of behavior, that nothing they did matters, and this undermines trying to escape. Why bother? And it gets back to what Seligman was saying, it doesn't matter, it just doesn't matter. Okay? Well, that was then. That was in 1967. Seligman's book came out in the 1970s, the book Helplessness, Learned Helplessness, which basically describes a lot of this research, but more importantly, had some very important implications, I believe, for how you would treat this kind of a problem and teach a person who is helpless how to be not helpless. Now we're going to take a 180-degree turn. Steve Mayer, interestingly enough, got out of experimental psychology as his main area of interest. And he seemed to go in a direction that was very different. He went into neuroscience. He did not stay in the field of experimental psychology, as did Seligman. He did not go into the field of cognitive psychology or clinical psychology for that matter. He said that the most important thing that he could probably do is to figure out what are the underlying mechanisms that are giving rise to this stuff. And he became very interested in neuroscience. And I'm going to go through some of Steve Mayer's research because he literally started an entirely new career and had to go back to medical school and had to learn all of the functions of brain and neuroanatomy to do the research that he was compelled to do. So now here is the theory, and I'm going to explain how he got to this. The passivity that you see where the person freezes or the animal freezes, or heightened level of anxiety where there's this running around, this heightened level of exaggerated behavior. Again, this is what Seligman was talking about, two kinds of depression. The one that you suppresses behavior and the one which seems to activate agitation, okay? Both of those are actually the default mammalian unlearned responses to prolonged bad events, such as inescapable loud noise and electric shock. It's mediated by the serotonergic activity of the dorsal raphe nucleus, the DRN, which ends up inhibiting escape. It's a brain function. It's the DRN, which, when stimulated by stressors, actually results in inability to escape. This is what gives rise to the freezing response. It's differential activation and sensitization of the DRN and the 5H neurons. Let me see if I could describe this to you for you, okay? This, imagine, is the DRN. Okay? This is the dorsal raphe nucleus. Stressors come into this and stimulate the DRN, which leads to essentially freezing, inactivity. So what is all this up here? Well, the research actually shows that there's another part of the brain called the ventral medial prefrontal cortex, the VMPFC. Okay. I'm sorry, let me go back to that. The VMPFC. This is the ventral medial prefrontal cortex. This is a part of the frontal cortex in which, if the animal or the human in the situation engages in behavior that is able to control stressors. For example, think of group number one. They had control. They had a lever, and they had a means to control the electric shock with a lever. That was pre-training. Then they had further ways of learning to control it by being able to jump from one side of the chamber to the other. There's two ways of controlling electric shock. These animals would be said to have stimulated the prefrontal cortex, because control is something which is actually, according to Steve Mayer, it's detected. Somehow, some way, the brain has been wired or has evolved that it is able to detect when it's actually able to control environmental events, when it's actually able to engage in behavior that functionally changes its environmental circumstances. And here's the really cool thing that he talks about. When the ventral medial prefrontal cortex is stimulated, that you are actually controlling those environmental events now, it has a feedback mechanism, which essentially, when this is stimulated, it shuts off stimulation to the DRN. Hence, no more freezing. Now you're actually back in control of this situation. Okay. All right. So what does this all mean? What does this all translate to? Well, passivity and this freezing up can be overcome by learning control and enlisting activity of the medial prefrontal cortex, the ventral medial prefrontal cortex. That results in detection of control, and it leads to the automatic inhibition of the DNR, which is essentially causing the animal to freeze. The ventral medial prefrontal cortex detects control thanks to the dorsal medial striatum, and then inhibits the DRN. This is one of the reasons why I find models so useful, is because before, all we were talking about were triggers and functions, which is all very important information. But when we start learning about underlying mechanisms, we are bringing in material causes. This is the four causes that I'm talking about. That is, we had an incomplete explanation of trauma. When you start finding out the underlying mechanisms that lead to the brain's functions and how they actually govern some of the functions of the body and physiology, it starts making sense. You start having a more complete picture. We start comprehending the picture. And again, comprehension, I'm going to use a metaphor here. Comprehension is when we could get our fingers on a particular problem, right? That's what it means when we talk about a prehensile tail. Prehensile tails are tails that are able to hang on to things, grasp things, right? And we are able to get our fingers on much more of what's going on with trauma when we are able to actually have all four of these causes laid out in front of us. So what does this really mean? In terms of treatment strategies, this actually implies a different kind of an approach than one might actually think about. there, according to Mayer, is that this implies a top-down cortical control is better, and it focuses on events of the future as what he calls an end run around bad events. How do you get around bad events? You need to talk about the future, not the past. The focus needs to be on the future. Okay, that's key number one. How do you get a person to shift focus to the future rather than constantly talking about what happened in the past? And here's one of the reasons why. I think that this is actually quite insightful. Reviews of past trauma in order to gain insight into causes will not likely work because of the DRN default reaction. The circuitry suggests that there is not much to be achieved by confronting, understanding, and reliving trauma. And what he's saying here makes a lot of sense. If you continue to have a person exposed to trauma, trying to use an exposure therapy in and of itself, just repeated exposure so that you could pull it off extinction, it's not likely to work because what you're doing is in the short run, you are stimulating the DRN over and over and over again. What you end up doing is that if you don't start looking at the future and changing your approach and just look at the past, you're going to have your patients either burn out or just give up because they will not feel like they're making any real progress by just rehashing the past. In contrast, in sharp contrast, you want to actually do not looking at the past, but prepare for the future, what is called future-oriented thinking, such as problem solving, crisis response planning, role-playing, assertive training. These are all the possibilities of things that you could do to get past the trauma. He emphasizes that what can be learned is cortical, and that is that bad events will not be controllable in the future. Okay, this is what you want the person to learn, that the bad events that they will be controllable in the future, that you can do something about it, that you're not stuck in a situation like the groups in like group 2 was, where the past is impinging upon the current present, that they actually can do something to make their lives better. So responsive expecting that future bad events will not be permanent, global, and uncontrollable. Rather, they will be temporary, local, and will be controllable. And this is the type of circuitry that has the metaphor, it's called the hope circuit. This was suggested by Mayer and by Marty Seligman, that this becomes the means by which we could possibly look at controlling responses to trauma, not necessarily only through cognitive therapy, but actually looking more directly at future-focused kinds of therapy, and most importantly, avoiding talking about the past. If you must talk about the past, if you must rehash that, recognize the fact that you may be re-stimulating the dorsal raphe nucleus. And if you start finding that your patients are not really responding to treatment, that may be an indicator, a good indicator, that you're too heavy on the exposure part and you're not strong enough in your therapy on the forward thinking and the forward training that you want to do. Okay, this concludes the training for trauma-informed and trauma-related disorders and adjustment disorders. I hope this has all been very useful for you. I'm going to stop sharing my screen. And there we go. I hope this has been really useful for you. I hope this has been informative for you. And I hope that at the very least, you are able to go forward thinking about this idea of trauma-informed culture and take trauma into consideration when you're doing your treatment with your patients. Thank you very much. Talk to you soon.